This video will demonstrate a technique useful for excising benign metaphyseal distal femoral osteochondromas in a minimally invasive manner utilizing arthroscopy. Our disclosures are listed here. To highlight this technique, we will use the case of a 24-year-old male with pain and occasional snapping along the lateral distal femur that was recalcitrant to conservative measures. Radiographs here show a osteochondroma along the lateral aspect of the metaphyseal portion of the distal femur. MRI imaging was also obtained and did not highlight any aggressive features. We do recommend consultation and clearance of such cases with orthopedic oncology or radiology as clinically necessary to ensure appropriate treatment. After consultation and careful consideration of the patient's persistent symptoms, despite conservative treatment, surgical excision was pursued by the patient. Standard infralateral and inframedial portals are used to initially access the knee and expose the lesion. Here, the synovium and joint capsule in the suprapatellar pouch are debrided to establish visualization of the entirety of the osteochondroma. This is done using an arthroscopic shaver and a radiofrequency ablation device. In this case, we are viewing from the infralateral portal and working through the inframedial portal. After thorough debridement, the osteochondroma should be well isolated from any soft tissue. Next, gaining control of the bony outgrowth is important prior to excision to prevent migration of the excised fragment. So to do that, we make an accessory supralateral portal localized with a spinal needle. When the lesion has a narrow stalk with a wider cap, we prefer to use a non-absorbable suture to control the fragment, but this could also be done with an arthroscopic grasper, but there's added difficulty maintaining grip when impacting the lesion with an osteotome and a mallet. So here, the suture is introduced and tied around the stalk, and alternating half hitches are used with an arthroscopic knot pusher to tie the knot. Now we are ready to perform our osteotomy and excision. We continue to work through the inframedial portal while viewing from the infralateral portal. The osteotome is introduced through the inframedial portal and impacted to osteotomize the osteochondroma as close to the femur as possible. This is done sequentially to avoid fragmentation of the excised piece. Any soft tissue attachments can be debrided using the radiofrequency ablation wand. And this piece is then pulled out using the attached suture and can be assisted using arthroscopic graspers, which can sometimes be required for smooth extraction. Once extracted, we inspect the piece and we can see the relative size of the fragment after successful en-bloc excision. Now we are ready to contour the resection bed, so we initially introduce a rasp through the inframedial portal and grossly file down any large sharp spikes. We then switch our view to look from the accessory supralateral portal. This gives us a nice en face view. An arthroscopic burr or shaver operating as a burr rather than oscillating is used to contour the resection bed. We like to perform this at various viewing angles from different portals to ensure a flush surface. Once again here, you can see another viewing angle for really meticulous contouring. Finally, here we can see the final product, as well as post-operative radiographs demonstrating complete resection of the osteochondroma. We thank you for your time and attention.